the question if it's not if the NAVA catheter is more work, and since all or most of you are pretty much used to NAVA, I ask myself if it is really the point in bringing up this topic at this time point, and also since you're placing the catheters in daily routine. So, however, and what also adds to this suspicious thought is if you look at the data and the publications, if you look at the meta sections, and what you can see there is that it looks like catheter placement doesn't make a lot of headache for those who are doing the studies. Look here, patient methods. What is written there were no difficulties in positioning the nasogastric tube, and this is more or less repeated. So there's not much space and wording placed in the manuscripts in order to describe how it was done or performed. So that leads to my thoughts on that one at that point. So, however, since we spent 2 days on NAVA in total, it might be worth to spend a couple of minutes on catheter placement procedures and just to repeat that and to bring ourselves to that point. So in order to get, of course, NAVA ready to go, we all pretty know that it needs a catheter in place in order to get the signal that is needed to drive the ventilator called Eadi, and what we have to think about how to get this catheter into this right position. So the point is, with the question, what causes more work, what causes us more work in terms of initiating NAVA? Of course, if we don't place a tube beforehand, we have to remove one tube in order to place a NAVA catheter, and then we have to place a catheter, we have to have an exact catheter position, and then further on, of course, we have to do intermittent controls in order to prove that the catheter is still in the right position and place. And as said, of course, in any case, that adds additional work if we compare that to conventional mechanical ventilation, where we don't have to run these procedures. So, initiating NAVA, what are the steps? We all know that functional test of the cable and ventilator, functional test of the catheter, and then there comes the catheter placement procedure, and then we have to jump into NAVA setting, and we already talked about that today with NAVA titrating, how to set the ventilator. So just briefly, we have the functional test, you're all aware about that. In order to know or to realize, to be sure that cable and ventilator are working properly, then we can test also the catheter ex vivo in order to make sure that we don't have a broken lead in there. I never realized that in the clinical practice. I never had any problems, but we still do that in order to be safe, since we don't want to be unclear about that when the catheter is in place and we don't have good or true signals. So that's beforehand, and then in order to get the catheter in place, we might calculate the estimated place, and therefore we can use the so-called NEX-measure, the NEX formula that has been implemented originally in order to get an esophageal probe safely into the stomach, and by modifying this original formula in order to get really the electrical area of the catheter into place, into the esophageal gastric junction, it has to be corrected compared to the initial formula. So, and then comes the next steps, catheter placement guided by ECG, where we can put in the catheter and follow the cardiac information, the ECG information, the P wave, which is showing up, and later on then the distal leads are moving towards the diaphragm. They get lower, and we don't see them anymore, and the ECG is showing up here in the early phase in the distal leads, and then moving through these leads that are displayed on the ventilator. So what else can we do? Another information we get from the height of the Eadi signal. As you see here, this would be a patient and the Eadi signal at different catheter positions. And you see here the so-called NEX-derived ideal position. And when we look here to the left, at a certain distance here, it's the odd position where there's a higher Eadi signal, meaning that the catheter is probably better in place at this position of the catheter. So the aspects we have to validate: QRS complex has to be there, gold complex in all 4 leads, breath synchronous EMG signal, so we should have these visible signs of the original EMGs, spindle-like signals in these leads, and then we look for the derived, calculated Eadi signal, and that should be, of course, distinct and stable, be seen on the screen. And there are another variables we can look at. The blue marking, there's a highlighted electrical signal where there's a highest activity used to create the final Eadi signal. Then we go for the PEEP, I already mentioned that. We have also further information by the ventilator, check information, check the positioning as an alarm that of course shouldn't be there, and of course we have also to look for noise and disturbances which can be seen on this catheter placement window. So what we did is look for catheter placements for NAVA, where we validated or tried to validate the available methods, looking for this next calculation, pre-calculation of an ideal place of a catheter compared to some of these variables we might use in order to get the catheter in place, the so-called opt or optimal position derived by these signals. And we did that in a study on altogether 20 patients, as you see here. We don't have to go into this table, it's just to show you that there's a high variety in patients included into this little observational trial: trauma patients, post-cardiac surgery patients, as well as neurosurgical patients and medical patients with sepsis or RDS. So what you see here is information can derive, as I mentioned. You see the Eadi signal at different positions with regard to the optimal position. You see the highlighted Eadi signal in the mean, that should be in the mean electrodes, and then you have this alarm information and the no P-wave information. And if you compare all these variables which we took into this optimal positioning procedure to this NEX formula, as you see here, then we get the information that the NEX, of course, gives us a good estimate to place the catheter. As you see here, we end up with a median value of 63 centimeters. It is close by altogether compared to the clinical evaluation, 65.7. However, you also have patients where this formula doesn't work at all, and there we get a more accurate finding if we look for these other variables. NEX-mod was possible, so NAVA was possible based on this formula in 18 patients, with 70% of the patients included, and are identical to this optimal positioning aspects in 4 patients only, that means 60%. So we get a good amount of information if we take these variables into account when placing a catheter. So the question, of course, is, are we doing that in the daily clinical routine? Well, we go for functional testing. Of course, we do that in order to make sure that the information is valid and not disturbed by ventilator problems and catheter problems. We go for the catheter placement procedure. We usually don't do the NEX-measure unless we see problems with catheter placements, and then we of course watch for the signals by positioning the catheter. So we had nice reviews when we sent this article in, and they asked us, what about PEEP, what about intra-abdominal pressure? And since we didn't did that at this time, we started the next little study looking for the influence of PEEP body position and EIP, intra-abdominal pressure, in 21 adult patients, cardiac surgery, neurosurgical, 5 medical abdominal surgical patients. So again, a group of overall possible surgical patients here from our ICU. And then we looked for catheter placement based on this OP method in these patients and changing in a randomized fashion from supine to 45% head elevation, PEEP of 5 and 15 centimeter more. We use also an abdominal belt in order to increase the abdominal pressure for this short period of catheter placement testing, and we put the patient also in lateral position in order to see effects by this lateral movement. And as you see here, over catheter positioning is of course, as expected, influenced by PEEP and increased intra-abdominal pressure. So with the PEEP, you move the lung down, the diaphragm down, and you get a shift, a slight shift, while with increasing abdominal pressure, you get an upwards movement of this optimal position. So this is the change of the optimal position compared to the initial baseline setting. And you see here the different aspects, PEEP settings, abdominal bell plus PEEP, supine, and upwards positioning. And on the right side, since we had patients who didn't have P waves because of atrial fibrillation, you see how this affects the settings. And interestingly, what we found is that those patients where sinus rhythm was existent, they had a slightly more cranial placement of the catheter compared to those who had the atrial fibrillation. So without atrial fibrillation, you were not that, didn't reach the best place compared to that. So daily routine, what we look at, I think that's the experience you have. These are just screenshots 2 days ago when I went to our ICU. We had at this time point at the one of our wards, 20-bed ICU, 4 patients on NAVA, and one was, they were all in weaning and they were all disconnected from the ventilator when I went to the ICU. And as you see here, all the patients are in place in terms of their signaling, the non-invasive patient as well as 2 patients who have been tracheostomized and being in the weaning period. So what else about catheter placement? Of course, you have to check the catheter every now and then, and as you see here, you have to ask yourself if the signals are still valid. This is a patient who right now, a day before, has very disturbing signals, as you see here by the screenshots and the main screen, where NAVA is not possible at all anymore. He was on NAVA for 2 weeks without any problems, but that shifted now. And what we realized is that he's always not functioning in certain body positions. And why is that? I don't have the X-ray on this patient. This is a patient with an left ventricular assist device internal. So the whole cardiac anatomy is totally changed in this patient, and therefore P waves are fluttering through and make a lot of disturbances in this patient. And therefore, again, you don't get the signals. They are nice when he's sitting. They are nice when he's in upward body position. But if he's on sided position, then you see these chaotic signaling where you have to change to an assisted mode of breathing. So, in conclusion, catheter placement is a rather easy procedure. I think you all probably agree with me on that point. You have to also consider placement-related complications. I come to that in the next slide. Of course, you have to take into account changes in body position, PEEP, or the clinical condition, where you should, of course, again confirm that the catheter is still in place, and this can be easily done by the nurses and the physicians at the bedside. So, another short point here. Problems related to catheter placement we have to consider, of course, when talking about this procedure. One, you can see here where the patient doesn't really have nice signals at all. oropharyngeal activity, but no ECG or diaphragmatic activity seen in the screens. And the reason you can see here on the right side in the X-ray is that the tube is on the false route, has been placed tracheally, and therefore no true NAVA signal, really high signal, was recorded in this patient. One of the complications, and they are not so seldom, so we have to take that into account, that catheter placement is related to a certain amount of complications, such as pressure or outflow stimulation, bradycardia, nasopharyngeal bleeding. We have mild positions in up to 15%, mostly due to esophageal position of the tip, but also rare complications such as perforations of the esophageus and the duodenum, endotracheal malpositions up to 4.4%, and of course the associated risk when it comes to such a complication. And we have also related infectious complications such as hospital-acquired sinusitis and ventilator-associated pneumonia. So these are the complications related to such a procedure, and that's something we always have to keep in mind when we want to decide to place a catheter in order to ventilate a patient. So bringing that together, again, extra work for catheter placement. For NAVA, it's of course a compromise because it is extra work, and we have to weigh these extra aspects like work and cost and complications against the benefit of the NAVA mode, the benefit of the signal we might use for monitoring in order to come to a conclusion. And I think the program here, the 2 days, will give the answer for you if it's worth the effort or not. So, with that, I thank you for your attention.